Assalamu alaikum. Today we are going to talk about the management of ruptured abdominal aortic aneurysm. So it's very important to know the phases of care for these patients and essentially where this pre-hospital state, where's the patient at, who's taking care of the patient, is the patient in another hospital, is the patient being taken care of qualified physicians, etc. It's very, very important to help guide the treatment. Direct transfers, as a patient, as a physician who's accepting transfer, you need to know a lot of information about the patient. You need to know what kind of rupture. I've had transfers and I've got burned before where they said it's ruptured aneurysm and turned out to be type A dissection. Some physicians don't know what the difference between that, unfortunately, or basically it's very important to know what exactly going on with the patient. Preferably you can have images. If there's no access to imaging or there's no way to can transfer images, you can at least ask them to show a text with a video of the CTA and so forth. So it's very important to know that information, because you could have a ruptured thoracoabdominal aneurysm and your facility is not capable of taking care of that. So you want to make sure before you go into trouble and transfer a patient, you can actually take care of that patient. If it's patient in the emergency room, how is the patient is doing? A lot of times these patients come with abdominal pain, back pain. They come surprisingly also. I've had few came in as a trauma activation. So they had syncope and they fall and they found them to have rupture aneurysm on CAT scans and so forth. Then you have, once you see a patient with ruptured aneurysm, then the next question would be, what is the risk, or you have to stratify the risks for patient survival. Can this patient survive or not? If the patient had 2-3 CP code blues, he will likely not to survive. Is the patient 95-year-old, 96-year-old? Discussion needs to be held with the family. So it's very important to stratify the risk and see what's the likelihood, if you do open surgery or endovascular surgery, if you do whatever you do, that you actually can help the patient survive with this procedure. Also, you need to know your capabilities and ancillary services. You need to know, whether you have OR versus hybrid suite versus C-arm. Do you have experienced anesthesiologists that can do sedation, then can do essentially general anesthesia as well. You have to have blood bank that can provide you with blood. If you do open surgery on these patients, sometimes you need a lot of blood and a lot of blood products, such as platelets, FFPs, cryo, so forth. Also, you need to know whether you have a good ICU management. You can do the best operation, and you don't have good ICU, the patient will die. You need to be aware of these complications that can commonly happen with these patients. If you do EVAR on a ruptured aneurysm, you have to watch for compartment syndrome. They can have compartment syndrome. Less likely that they will have ischemic colitis. Ischemic colitis is more common in an open surgery. Endoleaks, type 1A endoleaks, so forth. So you need to be aware of the complication. Essentially, the single most important issue, I think, you need to have a team in place. So you need to have a good anesthesiologist, good ICU doctor, good nurses. You need to have inventory. You need to have a blood bank. So team approach, you have to get. It's not just the surgery itself, but rather than just having a system in place where you can take care of the patient in all phases of treatment. And then once you're done, you need to send these patients to rehab and have access to that and so forth. This study is done in multiple institutions in Northern California and the state of Washington. I looked into the guidelines for transferring patients with ruptured abdominal aortic aneurysms. So first of all, if there's a vascular surgeon on site that is capable of doing these procedures, the patient should stay there and should be done. If there's no vascular surgeon, then you need to transfer the patient to another facility where they have that expertise, but you have to make sure that the patient is stable enough to be transferred. So, and then once you transfer the patient, permissive hypotension is very important to maintain blood pressure between 70 to 90. You do not want to over resuscitate these patients, because if you give them too much fluid, they're going to bleed out if they have contained rupture. So it's important to do a permissive hypotension. And my rule of thumb for these patients, if they're mentally okay, you're fine, even if their blood pressure is low. Transferring a patient who had multiple cardiac arrests is a futile care. So these patients probably should not be transferred. In transit care, the patient should have 2 good IVs, permissive hypotension. Basically, it's really the key role here for this issue, for transferring those patients. Rupture aortic aneurysms, so mortality is about 85% outside the hospital, 66% before reaching hospital or without an operation. Perioperative mortality for open repair is about 41 to 80 to 48%. Mortality has not really decreased in open repair even for the past 20 years. This is just a quick slide that shows the relationship between the size and the likelihood that the patient will rupture abdominal aortic aneurysms. So the